Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and this month, May, is Women's Health Month, and so we're going to be talking about diagnosing and treating endometriosis. And joining us today to talk about this is OBGYN Karen Berken with Willis Knighton Women's Health Associates. Good afternoon.
Hi, good to see you.
Yes, so we are talking about the diagnosis and treatment of endometriosis, and we were talking in our midday newscast, kind of previewing it and talking a little bit about this is kind of a common issue among women, but it may actually be more common because it's not really, we talk about it more, but there's still probably more things that we could discuss about this.
Yeah, it's definitely underreported.
So. Yeah. So first, before we get into the topic, tell me a little bit about what you do at Willis Knighton.
So at Willis Knighton, I'm an OBGYN, and so the OB part of it is obstetrics, so deliver babies, and then the GYN part is gynecology, and so that means anything not related to a pregnancy, but female health, basically, women's health.
And endometriosis would probably fall underneath the GYN part of it?
Yes, it falls under the GYN part of it. We typically diagnose and treat endometriosis when someone is not pregnant. So that, along with routine screening, pap smears, annual exams, hysterectomies, you name it. We kind of do a little bit of everything, deliver babies, surgery, clinic.
Yeah, and you said April was a busy month for you.
It was. There were lots of babies in April, lots of babies.
Awesome. I guess that's a good thing, but obviously a very busy schedule for sure. So tell me a little bit about what is endometriosis.
So the way that endometriosis comes about is still a little bit misunderstood, or we just don't quite have all the information yet. But the leading theory is that when someone has a period, you have the majority of your bleeding comes out vaginally, but some of it does spill backwards through the fallopian tubes. Actually, it's called retrograde menstruation. And if living cells from the uterus get swept up in that backflow of bleeding, then now they can basically seed anywhere in the pelvis. So a common place for endometriosis is kind of right where the fallopian tubes will empty. So around the tubes or the ovaries can lead to fertility issues, if endometriosis ends up there. And then also just where gravity takes it. So the lowest part of the pelvis, which if people have endometriosis down there, oftentimes they have pain with bowel movements, pain with intercourse, or just chronic pelvic pain.
Wow, yeah, so it's kind of hard to know exactly, maybe, unless you see, how do you look to see where this ends up settling?
So a lot of times you have to initially meet with a patient, ask them a lot of questions about their symptoms, and if they report a lot of those symptoms to you, then you can have a pretty high suspicion that they might have endometriosis. Unfortunately, really the only way to diagnose it truly is to go in and do a surgery. So it's a pretty drastic step, that someone has to be very uncomfortable to where this is really affecting their daily life for them to take that step often to have surgery. But oftentimes if people do take that step, they feel pretty vindicated in their symptoms, things that either others have told them or that they have kind of chalked up to normal, or maybe something that's just been in their head. Once you finally find it and have that diagnosis, they feel really good about knowing what was causing their symptoms all along. Sometimes you can see it on ultrasound if it's pretty severe. If you do an ultrasound or some type of an imaging study and you see a big cyst or a big collection of it that looks kind of complex in nature on ultrasound, so it has almost like a blood-filled appearance to it, then you can diagnose it, but oftentimes you don't know until you actually go in laparoscopically with a camera and you see it and you biopsy it.
Yeah, okay, and we did talk about this in our midday newscast. You mentioned that you know yourself and you know what your cycle feels like, so it may be sometimes hard to pinpoint if this is something that you're struggling with, because if it's your normal, then how do you kind of decipher from there if you do have this versus if that's just your normal cycle?
Yeah, and luckily women have started talking about it a little bit more and just talking about their periods more, and so you might be in a group of friends or female family members and just talking about different things, or they may notice how much ibuprofen or whatnot you're taking for your cycle, and people talk about how, oh, well, I don't have to take that much for my period. You know, why are you having to take so much? And that alone might be what kind of keys them into something abnormal, because it can happen from a young age, as early as periods begin, endometriosis can start. And so you might have had it basically your whole menstrual history and really think that what you were experiencing is normal.
Right, yeah. And so you would say taking excess amounts of ibuprofen is probably not normal, but it is normal to experience discomfort during your cycle, right?
Right. Everybody has some cramping and some discomfort, and other factors play into that, how heavy a cycle is. There's other pathology that can increase the pain during a period, but particularly in young, fertile females, premenopausal females, those are the patients that endometriosis typically affect because it is estrogen driven. And so once you go through menopause, it goes away. Okay. But in those young patients, it certainly is one of the leading causes of worsening period pain and infertility actually as well, and chronic pelvic pain.
Okay, and in midday, you mentioned about 10% of people this affects, but you kind of suspect it might actually be more.
The data shows 10%. That's 10% that's been diagnosed, by surgery and reported. So oftentimes the numbers are underreported. So by the data, about 10% of women that we know have this condition. And if you have certain symptoms, like infertility, for example, then probably upwards about 40% of females that struggle with fertility have some underlying endometriosis. If you have chronic pelvic pain, then it could be up to about 80% of females have endometriosis that struggle with chronic pelvic pain. So it's a big issue, and lots more women have it than they know.
Yeah, oh my goodness, wow. And so do you think that sometimes if someone is struggling with infertility, they go in for, maybe a surgery and sometimes they find endometriosis? Is that pretty common?
It is. Oftentimes you start with a basic infertility workup, labs, ultrasound, and then if you kind of go through that workup, everything's normal, but they're having pain symptoms, or even if they're not, but they're about to take it to the next step to see a fertility specialist, oftentimes they'll decide to go have the surgery, and sure enough, you find endometriosis, and that was your reason all along.
Wow, okay, but again, they feel vindicated because they're like, wow, this makes sense,
Right. Yeah.
So Vanessa, thanks for joining us, and what is your question for Dr. Berken?
I have a question. I'm 56 years old, and I do a lot of heavy lifting at work, and I've been getting a lot of pelvic pain. One of my coworkers said it's because you're doing heavy lifting, but I'm wondering, is that because of heavy lifting, or is something else is wrong in my pelvic area?
So it certainly could be because of heavy lifting. It could be, musculoskeletal issues. But there can be lots of other things, that are causing pain. You can have an enlarged uterus from fibroids. You could have had endometriosis in the past, which has developed scar tissue, so different structures in your pelvis are kind of stuck in places where they shouldn't be. And so as you move around or are more physically active, you feel more pain. There can also be bowel issues, bladder issues.
And I can barely walk. Like when I get up, and it keeps me from walking.
Yeah, and I mean sometimes the pain can be pretty significant. Even orthopedic pain, hip pain, arthritis, things like that. So certainly if it's affecting you to that level, where you can hardly walk, after a long day at work, I would. Whether you pick an OBGYN or another, specialist or your primary care doctor, it might be a good idea to kind of investigate that.
Okay. Thank you.
You're welcome.
Yeah,
Thank you so much.
Thanks, Vanessa. And if you're just joining us, we do have those phone lines open, and that number is right there on your screen. It's 318-219-4569. And if you did have a question for Dr. Berken, we are talking about endometriosis, and she's an OBGYN. So if you have a question about this topic, give us a call. That number is right there on your screen. So talking about endometriosis, we're talking about how it might be underreported, but is this something that can be genetic? So if other females in your family, they have endometriosis, should you also be worried that you might have it as well?
So it can be genetic. Now, we don't have a specific gene, that we know that we can test for, but there's too many coincidences. It runs in too many families, for it to not be some sort of a genetic component there. And risk factors for it are the earlier and more frequent you have periods, the later it is before you go through menopause, the less children you have, anything that basically would cause more frequent or heavier cycles can predispose somebody to endometriosis. So whether it's endometriosis itself or whether it's some of those other factors like heavier cycles, that run in families that can contribute to the genetic risk. But we do know that if a first-degree relative in your family has been diagnosed with it, you carry anywhere between about a 7 to 10-fold increased risk of having it yourself.
Wow, okay. And let's say someone is maybe taking hormonal birth control. Does that help or worsen endometriosis?
So it can help, mainly because it helps regulate periods. Depending on which birth control you're on, sometimes your period is stopped temporarily while you're on it, and so you wouldn't have as many opportunities to have that seeding of your pelvis from that retrograde menstruation. So birth control is one of the first-line treatments. Now the ultimate diagnosis and treatment is, going in and doing the surgery. We kind of discussed that a little bit. And there are some newer kind of advances technologically that can help us surgically treat and identify endometriosis. But once we know that it's there, typically you don't have to have, unless it's very severe, typically you don't have to have repeated surgeries. Once we've diagnosed it and we've treated it best we can during that first surgery, then there are some really good medications now available to suppress it until somebody gets to menopause.
Wow, okay. And how is it suppressing it? Is it hormonal regulation? Yeah.
Yeah, it basically dials down your estrogen levels enough to where you cut off the fuel line for endometriosis, and so that it'll regress on its own.
Okay, interesting stuff. So is someone that has endometriosis, are they at risk for like maybe even cancer later on in life, like uterine cancer?
So there's not a direct link to cancer, but it is an inflammatory condition.
Okay.
So anything that causes increased inflammation anywhere in the body can potentially, lead to more cell turnover, more cell damage, and therefore cancer down the road. So it could be an indirect factor.
Right, okay. And is there staging for endometriosis, like stage 1
There
to
is.
worse? Okay.
So it's staged, stage 1 through 4, stage 1 being minimal, stage 4 being the most severe cases. The staging is based off of surgery. So if you go in and actually have the surgery, depending on where the implants of endometriosis are located, are they on the tubes, the ovaries, just on the lining of the pelvis, which is called the peritoneum, or is it deeper? Is it a superficial or is it a deeper endometriosis, and just how extensive, how many implants are there? In very severe cases, stage 4 cases, it basically looks like the whole pelvis has been cemented to itself. I mean, there's so much inflammation, so much scarring that it's sometimes hard to distinguish between what structure is what.
Wow, yeah, and so that would be, you're having the infertility issues probably at that stage, and
Yeah, absolutely.
lots of pain.
Yeah.
Okay.
And way before that typically is when people have pain and infertility issues as well, yeah.
Okay, so hopefully the pain is severe enough to where they're going to get it checked out. You're not waiting, because it can, I guess, worsen over time, I'm assuming, or it just maybe depends on your body.
Yeah, sometimes it stays about the same, but it certainly can worsen over time. That's the typical course of it, is that over time, unless you seek treatment, it does progressively get a little bit worse.
Okay, and you mentioned throughout the cycle, so you can experience the pain. It doesn't have to just be during your period.
Right.
Right. Okay. Do you, from your patients, what do they report it feels like?
It's different for everybody. Yeah. A lot of times it's sharp shooting, intense cramps during your cycle, pain with bowel movements, pain with intercourse is pretty common. But people can often localize it pretty well too. They'll say my left ovary just always seems to hurt in the middle of the month, and I can almost track it on a calendar. that's a pretty classic sign that maybe they have endometriosis over there close to their left ovary.
Okay, and it's pretty severe pain, or is it just like I don't know. It's hard to pinpoint.
It's hard for people to characterize sometimes
right.
because there have been plenty of cases where people are in severe pain and you go in and there's maybe 1 or 2 small implants of endometriosis, but they're in the perfect spot to where they're right over a nerve or somewhere that's very sensitive. And there's other patients that have hardly any symptoms at all, but maybe decide to have the surgery for an infertility reason or maybe just heavy periods, maybe they're wanting a hysterectomy, and you go in and you find it everywhere, and really they don't report many symptoms at all. So it's kind of hard to gauge, you know, based off of degree of pain, really.
Okay, and so let's say if someone was just worried about having endometriosis, could they call their OBGYN, say, Dr. Berken, you know, this is something that I'm, you know, a little worried about, maybe they're having infertility issues. Could you go, it kind of be like a diagnostic surgery to where you're going laparoscopically and maybe not even removing anything, but you could go in and see.
Right, yeah, so if somebody signs up for the surgery, then I tell patients it's diagnostic and therapeutic. You know, at a minimum, we're putting a camera in and just looking around through one small incision. If we don't see anything, then we can just take the camera out. But it's also therapeutic in the sense that if we do see something, we're going to biopsy it, burn it, get rid of it, take down any scar tissue while we're there in the surgery. So they're consented for both the diagnosis and the treatment before we start the surgery.
Okay, yeah, and even if you don't find anything, you know, peace of mind for sure,
right?
And that kind of thing. So what happens, let's say they have this surgery and there are some therapeutic measures, you know, you're going in and burning and doing whatever you need to do. What is the recovery like after that?
Typically, the recovery is not too bad. You know, laparoscopic surgery, you can look at maybe about a week or so of downtime from work as long as you're not doing any real strenuous activity or heavy lifting. Another week or so before you feel, you know, basically back to normal. I normally follow up with patients at about the 2-week mark, and almost everyone at that point is back to about 95%, you know, of their normal activity. So the recovery is typically not too bad unless it's really severe disease, and then it's an outpatient surgery, so you have it done, go home same day. You typically don't have to stay a night in the hospital either.
Yeah, nice. And usually they feel an improvement in those symptoms almost immediately. Yeah,
they often do very well with postoperative pain because they're conditioned to have hurt for so long going into it. And so I hear quite commonly that after the surgery that the pain of the surgery doesn't compare to the pain that they felt before.
Wow. Okay, so sometimes it just might be worth it.
Yeah.
Just to know that, you know, I'm in so much pain now. If it's still surgery, but it's not going to be probably comparable to where they're at. Okay. Yeah. Well, that's good to know. And so when should someone, you know, seek help? Like, let's say they're at home and they maybe identify with some of these symptoms. When should they, you know, call and make that appointment?
So really any time after someone starts their period, if they're noticing some of these symptoms, reporting these symptoms to any, you know, parent or loved one, or then they are more than welcome to call, you know, and schedule an appointment with an OBGYN. Oftentimes these are symptoms that we ask about at routine annual visits too, so someone might not necessarily even come in thinking that they have symptoms, but we get to asking questions during the interview during their annual exam, and lo and behold, we're checking all the boxes, you know, as we're going through, and then we start a conversation at that point, you know, about maybe treatment options or some testing that can be done to see if they have it.
Okay, and so this is something that they could also check at they should be checking for at their annual exam. So it's something that they may already know because of those symptoms, like the symptom checking that you mentioned. So, okay, so the medications that you were talking about that can help this condition, is there anything else that you can do without taking medications, without having surgery? Is there anything else that anybody can do, whether that's, I don't even know, is there anything else in their toolbox?
So you can't change when your period starts or when your period stops, but birth control can be protective against it, particularly if you have heavier cycles. Also, really, you know, this is not a exact reason why someone would want to just have a bunch of children.
Yeah.
But the more children someone has, and if they breastfeed those children, both being pregnant and breastfeeding are low estrogen states in the body. So your progesterone hormones are pretty high, your estrogen is very low, and so because of that, people with endometriosis typically feel great while they're pregnant and breastfeeding. Typically their pain symptoms will significantly improve or go away. And that's because they are self-treating by cutting their estrogen levels down. So certainly a perk of having babies, so one preventative strategy would just be to have, as many children as you want. But outside of those things, really it's kind of on autopilot, and it's really out of someone's control.
Right. Okay. And so let's say they have the surgery, they're feeling much better, but there is a risk that the next cycle they have, it could come back, right? It could, as you mentioned, the retrograde. Is it kind of idiopathic, like we don't really know why it happens, kind of?
Yeah, and there's so many factors that go into it, but a lot of times, let's say I do surgery for someone and we find it, and I feel that during the surgery we have burned and gotten rid of any current areas of endometriosis. Then at that post-operative visit, I have a conversation with the patient saying, at this moment, I think we've gotten it all, but it can always return. As long as you're premenopausal, it can return. And so I give the patients the option of starting a medication at that point to prevent it from coming back, or we can just track their symptoms. So let's say they feel great for the next 5 years, but then at the 5-year mark, they start to feel those pain symptoms return. Instead of going back for another surgery or waiting, we know most likely what's causing the pain, and so then at that point we would start the medication.
Oh, okay. And the medication can reverse some of that? Or
it can
stop
basically make it regress and treat it,
Okay. And if someone is on these medications that you're talking about, which maybe, do you mind listing them, like what they're called?
Well, so there's a lot of different names and types out there. Some of the older medications, one of them was called Depo-Lupron. It was pretty harsh as far as side effects go. It was a injection that you got once a month. You could only be on it for a certain period of time because it was so strong. So you could only be on it for about 6 months at a time. And the side effects, hot flashes, night sweats, mood swings, all the menopausal side effects, because you're making your estrogen levels really low, were pretty severe. Now there are medications out there that are in pill form. You take it once a day. You can take it for up to 2 years continuously because it's not as strong and as much more effective. And there's even some formularies out there that have just the smallest amount of estrogen added back into the medication, which sounds a little counterintuitive. You're trying to cut down somebody's estrogen levels, so why are they including estrogen in the medication itself? But that dose of estrogen is meant to mediate those side effects, but it is not enough to actually affect the overall efficacy of the medication.
Gotcha. Okay. And if someone was still, like, they have the surgery and they have the option to do the medication, would you recommend the medication for someone that still wants to have children?
So yes, the medication is a very good option. You are not supposed to, and it is actually difficult to get pregnant while taking the medication. So if you're on the medication actively, you need to use some other type of method to where you are not getting pregnant while you're on it. And then as soon as you get off of the medication, your estrogen levels return back to normal, and you can try without any issue. It doesn't have any delayed effects or any effect negatively on infertility once you get off of it.
Awesome. Okay, so you want to treat this first, the endometriosis, right? And maybe get that under control, and then maybe have a plan moving forward if you're still wanting to have children.
Yes.
Yeah. Okay. So with the technology, you're doing laparoscopic surgery. How have you seen it change maybe since you've been in practice?
Used to be, long time ago, we didn't even have laparoscopic surgery. That was before my day, but long time ago, they were able to, you had to basically have an open surgery. Now we have laparoscopic surgery, we have robotic surgery, which allows us to have very, very detailed cameras, 3D imaging, really fine motor skills, better than a human hand. And there's also this neat technology called Firefly that the robotic Da Vinci robot can use, where you inject a fluorescent dye that shows up under a special infrared light that you use with the camera. And so any areas in the body that are drawing more blood flow, so endometriosis being one of those areas, cancer being another one, you can use this Firefly technology to basically light up a bright green fluorescent glow on all the areas where endometriosis is, so you can do a more thorough exam and a better treatment of it.
Very interesting. Well, Cindy, thanks for joining us, and what's your question?
Yes, I have what feels like cramps throughout the month that feel like I'm about to have my period, but it's not at the right time, so it's along, maybe 2 weeks apart from my period. And also, so that sounds like that might be the endometriosis, but also I feel like I have swelling, maybe from my ovaries all the way down to like the vaginal tissue. It will just inflame some for a while and then go down. And I'm just wondering if that might have something to do with endometriosis also.
It could be.
I've been given prescribed just to take an allergy medicines in the morning and the evening to try to help with that type of swelling and redness that feels like it goes, like I say, all the way to my ovaries. And it does help some, but it's still, the symptoms do still persist, but they are helped with that some. I didn't know if that could be related.
Certainly could be. A lot of times when you have the pain that you're having, that's one of the classic symptoms of endometriosis. It also causes inflammation all throughout the pelvis. It can be near the ovaries, the fallopian tubes, or low down, really anywhere in the lower pelvis. And so, if you're having a swelling or a fullness feeling, a lot of times people even report kind of like this just general bloating periodically throughout the month. Those can all be signs and symptoms of endometriosis, so it might be worth getting it checked out.
Okay, well, thank you very much.
You're welcome.
Yeah, thanks, Cindy. And we have just a couple of minutes left, but we did talk about preventative strategies once you know that maybe you do have endometriosis, but are there any other things that people can do to prevent their risk of endometriosis, or it's kind of one of those things that you really can't?
A lot of it's kind of non-modifiable, risks. Certainly doing your routine screening, going to your annual exams, seeing a doctor on a regular basis, because sometimes we can either, by questioning the patient or on the actual physical exam, we can either feel it if there's an area that is big enough or a large cyst on the ovaries, or we can elicit certain symptoms or pain in certain areas of the pelvis during the exam. And so if we are feeling in a certain area and they jump, because we've hit kind of a sore spot, and it's in the classic areas of endometriosis, that alone can kind of start the conversation.
And that's something that, like, as we mentioned, that you are checking for in an annual exam. Okay.
Yes.
And that's really highlights the importance of going to, and attending your annual exam. It's free, right? And so if someone has not established care with an OBGYN, are you accepting clients right now?
Yes, I am. And there's, you can easily get in touch with us. I'm based at Willis, Knighton, Bossier at Women's Health Associates. And so I'd be happy to take care of anybody. I have lots of good partners. There's lots of great OBGYNs in the area that are also doing these types of surgeries as well.
Great. Okay. Do you have a good phone number that someone could call?
So the main office hotline is 318-212-7931.
All right. Yeah. So it's really important to get established, not only for endometriosis, but other things. Getting the annual Pap smear and what other things are important in that visit.
Yeah. I mean, depending on age, birth control, talking about pap smears, mammograms, colonoscopies, overall women's health, mental health is a big part of that, sexual health. You know, there's so many different components that go into that annual exam, and really when someone's coming for an annual, a lot of times it becomes a problem visit because there's a reason as to why they're there. You know, half the patients come because they just want their pap smear. The other half haven't really had an annual in a while, but they decide, oh, maybe I should go get one because this has been bothering me, and so then they'll schedule the annual appointment and we can talk about it then.
All right. Well, great tips, and I learned a lot today. Thank you, Dr. Berken.
Yeah.
Thanks for joining us. This will also be on our website at ktbs.com/podcast.